This class, we're going to talk about the definition of epidemiology. I'm going to introduce the Socioecological Model, which you may or may not have seen before in other courses. We're going to talk about how we measure population health, and we're going to start talking about measures of morbidity and mortality, which we'll revisit again and repeatedly throughout the course. Different organizations define epidemiology differently, but a couple definitions I like are that it's the study of the distribution of disease and the factors that determine that distribution. And from the World Health Organization, epidemiology is the study of the distribution and determinants of health and disease in human populations to enable health services to be planned rationally, disease surveillance to be carried out, and preventive and control programs to be implemented and evaluated. One of the key assumptions of epidemiology is that diseases are not random. Epidemiology determines how much of a disease is out there, who has it, where it is, and the extent of the health problems it's causing in our population. By understanding the risk factors for disease and preventive factors, we can use that information to inform health interventions. Another purpose of epidemiology is to understand the natural history of a disease, which we need to know in order to design an effective intervention in order to decrease morbidity and mortality from that disease. You're probably already familiar with the public health process from other courses, but I wanted to mention it briefly as a reminder that in epidemiology, you're using a lot of the same processes and underlying principles as in other areas of public health. You're always going to start with a community assessment, and you need to describe the issue using data, and you want to develop interventions based on the data. And interventions should always be community driven. So if you're working in a community that isn't a community that you're a member of, it's especially important to make sure that you aren't an outsider telling other people what they should do for their community, but instead you want to work with local leaders to ask them how you might be of assistance to their community. This is something I've seen some people do that are coming at public health from a different background that can go badly in the sense that your work won't be impactful usually if you don't have the engagement and cooperation of the local people in the community. If you're an outsider just sitting at your desk behind a computer and you're doing epidemiology, but you're not actually talking to the people impacted by the problem, it's very likely that whatever paper you publish or end product you come up with won't actually get used for anything because the people in the community might not even read it. And if they do, it might not reflect their perceived needs, or the intervention you come up with might not be acceptable to them for cultural reasons. So I just want to remind you that you have to go back to these basic principles whenever you're doing work in epidemiology. Another reminder is you should always plan your evaluation before program implementation. Evaluation needs to be something that you're thinking about at the beginning, not only at the end. If you plan a program and you implement it, and then after it's already up and running, then you think, oh, how am I going to evaluate this? That's bad. You don't want to be in that position. You got to already have planned for evaluation at the beginning of the cycle. And another underlying goal, like with other public health work, is we're trying to reduce health disparities and improve population health outcomes through health promotion, disease prevention, and systems improvements, such as environmental and policy changes. So your intervention when you're doing work in epidemiology isn't necessarily like a vaccine. It could be a policy. It could be something at a different level, but the same basic objectives remain the same. Whether you're coming from a clinical background, most of us are much more familiar with how we measure the health of an individual person than how we measure the health of a population. In epidemiology, as with other disciplines within public health, our focus is on the whole population, whether that's a city, a country, or a community served by a particular health department or a community health center, which is different from medicine, nursing, and other clinical health professions where the focus is at the individual level. In healthcare, we strive to help each of our patients improve their health and meet their health-related goals. But in epidemiology, it's like we're zoomed out and looking at the whole population at the same time. And our objective is to help that whole community or population improve their health. For an individual, we might look at metrics like the person's blood pressure. And on the population level, we might look at metrics like life expectancy, mortality rate, fertility rate. These are analogous ways of evaluating a population compared to one patient in front of you. Measuring disease impacts, the same sort of thing. For an individual, we might look at symptom progression as an example. But on the population level, we might look at years of potential life lost, quality-adjusted life years, disability-adjusted life years, incidence, and prevalence. These are all things we're going to be talking about in more detail later. But I just want you to be familiar with these terms in general and that they are measures of the impact on a population level, not of an individual person. And talking about evaluation again, if we're providing healthcare to patients directly, it's straightforward to figure out, did the person's blood pressure go down, or is it the same, or is it getting higher? And on the population level, we have to build in evaluations to interventions in order to determine if the outcomes were improved at the population level, if the target population is becoming healthier because of the work that we're doing. This slide presents some comparisons between health outcomes in the United States and other countries. On the left, you see infant mortality rate. The United States is way down there, and that might be surprising to some of you. With obesity prevalence, that probably won't shock many people, but you'll see yet again, we are an outlier in the United States. And life expectancy at birth, again, we're down between Chile and the Czech Republic. Most of the European countries you might intuitively think that we would be similar to have a much higher life expectancy at birth. For example, Spain is 83 years. So if a baby is born in Spain, we would expect that baby on average to live to be 83 years old. But if a baby is born in the United States, we would expect the baby to live to be 78 approximately. This graph shows life expectancy at birth by race and Hispanic origin in the US from 2006 to 2016. On the x-axis, we have the year, and on the y-axis, we have age. It's important to note when looking at a graph like this, see those two little diagonal lines? That tells you that there's a gap in the information that isn't displayed. So you see the age goes from 0 to 65, and then after that, it's only a 5-year difference. This graph of life expectancy at birth by race again shows disparities. A disparity is a difference in health outcomes between subsets of a population based on characteristics such as socioeconomic status, race, sexual orientation or gender identity, geographic location, or other factors. A central goal of public health is to reduce health disparities, but unfortunately, health disparities have persisted in the United States. The United States spends more per capita than any other country on healthcare, but our country has focused on caring for people who are already sick, for example, with hospital care and treating conditions that have already developed rather than on preventive care, like public health typically focuses on. And that approach is much more costly for the country. More resources were diverted towards public health during the COVID-19 pandemic temporarily, but we've already seen budget cuts and programs ending that were funded during the pandemic. So there might not be that much of a lasting impact in terms of dollars allocated for public health rather than acute care and hospitals. One of the downsides of our system that spends so much of our healthcare dollars on hospital care is that healthcare overall is only about 10% of what creates a person's overall health and well-being. The social determinants of health are a framework for thinking about the things outside of the healthcare system, and the healthcare system is included within that, but all the different factors that impact health outcomes. These are a lot of the health outcomes that we're going to be talking about in this epidemiology course. Epidemiology isn't just about infectious disease, it's also the study of chronic diseases, injuries, and health-related behaviors. And it's important to remember that people don't exist in a vacuum. People interact with their immediate environment, their community, and their government. This is a version of the Socioecological Model, which is based on the theory by Uri Bronfenbrenner. His theory argues that the environment you grow up in affects every facet of your life, and health is impacted by the interactions between all these levels of the system that surround a person. And we can't understand health behaviors without taking into account the factors external to the individual and the influence of those factors. You do not need to memorize the different levels of the system or the different components. Similar to the definition of epidemiology, this is different from different sources, but the concept here is that there's different levels around a person, and the systems that a person is living within have an influence on community health or population health. For example, the transportation system is important. If a person can't walk to school, that has an impact on their overall health. You can look at the different things on the slide and think about examples of how each of these things might have an impact on a person's health and the relationship between these different factors if you're going to try to design a program or try to study a disease in the population. For knowledge checks in this course, I'm going to read each question and then I'll put up the little pause icon so you can stop the video and answer the question on your own and then continue on at your own pace. So here's our first practice question. Health disparities are differences in health and healthcare between population groups. Which of the following is the best explanation for why the U.S. spends more per capita than any other country on healthcare, yet our health outcomes are the worst of any high-income nation? The United States focuses on treating people after they're already sick rather than on preventing disease from developing, which is much more cost-effective. Continue to part 2 of the lecture by clicking on the next video.